Hello, good afternoon. Thank you very much for attending today's webinar. So I will present today about how to share HIPAA in what I would characterize as a share data according to HIPAA in a responsible way, it's health data. My objective is to give you a conceptual overview of the de-identification components in the HIPAA Privacy Rule. So I'll try to cover the key issues and describe what works and what doesn't work, and give you a few examples and metrics along the way, and also to help you understand the trade-offs that need to be made when you are releasing data or disclosing data for secondary purposes. An important point to make is that I am a computer scientist, and therefore if you have legal questions, I will answer them with a computer scientist hat on, but otherwise you should consult with a HIPAA lawyer if you really want to understand the subtleties of the law and the regulations. Also, I wanted to mention that at the end of the presentation, I'm going to give you a link to a web page which will have all the material that I reference, links to various articles that I reference, and tools and so on. So you'll have access to all of that material at the end. So when I'm talking about sharing data under HIPAA, I'm talking about sharing the data for secondary purposes. So this can be for research, public health, commercial uses. And in general, when you're disclosing data for secondary purposes, there are really two ways to do it. One is if you obtain authorization of the patients, and that can be very challenging because for large databases, when the data already exists, obtaining authorization from a large number of people is not practical and may not be doable. And the other approach is to de-identify the data, which is what I will be talking about. We've been working in this space for quite some time, and we've published a number of articles on the de-identification of different types of data, so claims data, discharge data, and prescription records data. So there are a lot of good sources that describe the methodology and the approach that I'm going to go through, as well as provide concrete examples of actual data releases, public data releases, as well as commercial data releases. So HIPAA applies to covered entities, and covered entities are defined as healthcare providers. So these are doctors, clinics, psychologists, dentists, chiropractors, nursing homes, and pharmacies. Health plans, so these are insurance companies, HMOs, and healthcare clearinghouses. And more recently, the HIPAA has been extended to apply to business associates, who are essentially subcontractors to these covered entities. If you're not within the scope, then HIPAA would not apply to you. So all the de-identification standards or regulations under the HIPAA Privacy Rule would apply to covered entities only, and not to other types of entities. So, for example, if you are collecting data, you have a medical device, collects data on activity, for example, and the individual consumers are augmenting that data with the activity data with some demographics and maybe some other medical history information, and you're collecting that directly from the consumers, then and you're web-based, building a web-based tool and so on, then you would not be a covered entity, for example. So in this case, HIPAA would not apply to you. However, and also personal health records would be another good example. So PHR vendors who are collecting data directly from patients would not be, the data collected from the patients would not be covered under HIPAA. However, it's always, or my recommendation would be that it's always good practice to follow the HIPAA regulations for de-identifying data for a number of reasons. It's just good risk management. that if there's ever a breach on the data that has been collected, then following the HIPAA Privacy Rule standards will also provide you with cover in the sense that you don't have to notify the individuals if there's an actual breach. Notification can be very expensive, and if the data is considered de-identified, then it's no longer personal health information or protected health information, then there's no need to notify. Notification costs have been estimated to vary from $200 to $300 per record. This includes actual notification costs, penalties, compensation for the individuals affected, lost business, and litigation costs. So they can be quite costly if there's a notifiable breach, and if the data is de-identified according to HIPAA, then one can make a very good case that this is no longer protected health information, and therefore no notification is required. There's also the issue of maintaining patient or consumer trust. If you're collecting health data from consumers, and you want to then use it for secondary purposes, either to do research on it or share it with partners, or give it to public health agencies, for example, then maintaining consumer or patient trust is very important. There's evidence that patients adopt privacy protected behavior when they have concerns about how their health information is being used. So in the U.S., based on surveys of U.S. adults, 15 to 17% have admitted to lying to their doctor or not providing complete medical histories, seeing multiple providers, not seeking care, self-treating or self-medicating in order not to have their health information entered into some kind of medical record. This is a socially undesirable thing to do or say. I lied to my doctor, so 15 to 17% is probably a low estimate. Surveys of patients, not just general public, but patients were much higher in the 40 to 50% admitting to some of these privacy protected behaviors. And the most vulnerable populations tend to exhibit this type of behavior most, such as adolescents, people with HIV or at high risk of HIV, those undergoing genetic testing, mental health patients, and battered women. So there's an issue of data quality as well. If there are concerns about how data will be shared, then we do know that individuals adopt privacy protected behaviors and essentially corrupt their data. And finally, you may have contractual obligations as well. So if you obtain data under a terms of use or under a contract, then that may require the data to be de-identified if it's used for secondary purposes. So even though you may not be a covered entity, following good practices for de-identification may still be advisable under a number of very general conditions. So in HIPAA, the definition of de-identified data is on the screen. It's health information that does not identify an individual and with respect to which there is no reasonable basis to believe that the information can be used to identify an individual that is considered not individually identifiable. I've highlighted no reasonable basis because that's very important. It's a reasonableness standard. There's no expectation of absolute guarantees. A case has to be made that there's no reasonable basis that an individual can be identified, and that's all that's required in order to meet these requirements. This is quite normal in the sense that in many other jurisdictions, the definition of personal health information or protected health information or identifiable information is very similar. Most jurisdictions do use the reasonableness standard to determine what is PHI. So before jumping in and talking about identifiability of health information, I just want to cover the issue of reidentification attacks. There's been, and as I say, I wanted to clear that out at the beginning. So there have been some claims made over the last few years that health data can be, or data in general actually, can be easily re-identified. That de-identifying data is not something that we should do because it can be easily re-identified. and a number of examples have often been used to make that case. So I will go through those examples, and not all of them, just a couple of the better known ones in order to counter that argument. Because when we analyze the evidence, the conclusion from the evidence is that if you de-identify the data properly, and I'll define what properly means, then it is very hard to determine the identity of the individuals, to re-identify the individuals. But it has to be done properly. If you do a lousy job, then it's easy to re-identify. So I'll look at three highly publicized examples of re-identification attacks and explain, what happened and what we can learn from them. So the first one is the AOL example. So in that particular case, AOL posted search data on their website to make it available to the research community to develop new methods for analyzing search data. So this is not specifically a healthcare example, but it's an example that's used quite often. And then soon afterwards, New York Times reporters were able to re-identify user number 4417749. So all the usernames were replaced by pseudonyms, which are these random IDs or IDs, but you could track an individual's search queries using their ID. So user 4417749 had entered search terms such as T for good health, numb fingers, hand tremors, dry mouth, 60 single men, dog that urinates on everything, landscapers in Lilburn, Georgia, homes sold in Shadow Lake Subdivision, Gwinnett County, Georgia. And using those search queries, the New York Times reporters were able to figure out that user was Thelma Arnold, shown here, with one of her dogs. She's a widow living in Lilburn, Georgia, and she has 3 dogs. And that's used as an example of a re-identification attack. The problem here is that, a couple of things. Thelma actually had entered her exact location in her county and exact location in her search queries, and in one of the other queries, which I didn't show here, she'd entered also her surname. She was looking for other Arnolds. So it's very well known that many people do vanity searches in the sense that they enter queries about themselves. So just by looking at the search queries, you're able to figure out who the person is. And there's also evidence that it's quite easy to determine for many people, not everybody, but for many people, their geographic location as well. So search queries would not be considered under any reasonable standard as de-identified data, even if you have removed the username and replaced them with pseudonyms. So as an example of re-identification, that would not qualify. The second example is Governor Weld of Massachusetts, who had an incident where he was unwell. He collapsed during a public presentation or public appearance, and the collapse was covered in the media. And then a researcher was able to, using insurance claims data that was semi-publicly available, it was data that could be bought from the Group Insurance Commission, then that researcher was able to identify the transactions, the claims that belonged to Governor Weld, and determine why he went into hospital, what the cause of that collapse was. And that actually re-identification attack had a huge impact on HIPAA itself. It happened before HIPAA, but it's a commonly cited example. Again, of a re-identification attack. So the fact that it happened before HIPAA means that none of the de-identification standards that were used in HIPAA, that were defined in HIPAA, were used to protect the data. So I think that kind of attack would be very difficult to conduct today for a data set that followed the HIPAA standards. And then a more recent analysis indicated that Governor Weld would have been re-identified anyway, just because he was a public figure, and all the information that was required to re-identify him was publicly known in the media, such as his admission date, his diagnosis, and his discharge date, as well as his gender and date of birth, which were public information. So the re-identification attack by matching the claims data with a voter registration list, which is a commonly cited example, was would not have required a voter registration list because there was a lot of information publicly available. And then there's the issue of voter registration lists being incomplete, and the probability of a successful attack for anybody other than Governor Weld would have been considerably lower than we assume. So there are a number of issues with that attack. And then the last example, which again receives a lot of attention, is the Netflix Reidentification. So this is not a health data example, but the situation was Netflix had publicly released movie ratings data in the context of a competition. They wanted to develop a better algorithm to recommend movies with a large cash prize, and so they made this data available, and researchers matched the Netflix data set with another publicly available identifiable data set, the IMDb database, which is another movie ratings database. Because of this attack, a second competition that was attempted by Netflix was canceled, and there was some litigation as well that followed because of this alleged Reidentification attack. The problem with the Netflix attack was, first of all, we don't know whether the Reidentification was correct or not because they were not verified by Netflix. Then the second problem was that the authors of the attack actually admitted that the Netflix data was not de-identified. So it does not really tell us much about what the method that Netflix used and how good it was for protecting the data. And then the false positive rate of the matching was not actually evaluated. So we don't know how many people in Netflix database were actually in the IMDb database. And I cannot imagine that everybody who goes to Netflix to watch his movie, and Netflix goes on and rates them right away on IMDb. And surely there's an overlap, but we just don't know how big that overlap is. So there are a number of questions about that attack in terms of its false positive rate and whether the original data set was de-identified to start off with. So those three examples, which are three common examples, do illustrate that the evidence is not as compelling as the sound bites make it seem, that there were not that many attacks on health data. So this is an article which reviews all that evidence, and there were 14 publicly known Reidentification attacks, and only 6 of them were in health data, and only one of those was on data sets that were properly de-identified according to the HIPAA standard. And that particular case, the risk was 0.013%, which is quite low. So I'll leave it at that. I'm not going to belabor this point because I think the evidence, and if you go and read this article, the evidence is not supportive of a general concern about the identification, but it has to be done well. This is really an important qualification. It has to be done first, and then if it's done, it has to be done well. Okay, then the next point I wanted to cover regarding HIPAA de-identification is the difference between attribute and identity disclosure. This is a slightly technical point, but I think it's a very important one because it's confused quite often when people talk about privacy, data sharing, especially sharing of health information. So there are two types of disclosure that, if you have an adversary who's trying to attack a data, there are two types of disclosure that we may be concerned about. Attribute disclosure is when you discover something new about an individual in the database without actually knowing which record belongs to that individual. And I'll give you a few examples. But the key point here with attribute disclosure is you do not know which record belongs to, say, Bob. With identity disclosure, you determine which record in the database belongs to Bob, and since you know which record belongs to Bob, you can then learn all the things about Bob in that database. If it's a claims database, you'll know their procedures, their diagnosis codes, and when they were admitted, visited a hospital, etc. HIPAA only covers or talks about identity disclosure. And this is really important because if there is an attribute disclosure, it is not covered by the regulations. I'm not going to make a judgment call about whether this is good or bad. It's just the way it is. So let me give you some examples to illustrate. So this is an example with HPV vaccination. And I'm taking a mild example so as not to be too controversial, only a little bit. So here we have a data set which has two variables, the religion of individuals and whether they've vaccinated their teenage daughters against HPV. And there's strong evidence that HPV, the virus, causes cervical cancer. So there's a strong incentive to vaccinate women at a younger age. So in this particular case, we can, until we tabulate the data and we get this 2-by-2 table, and there's a strong relationship between religious affiliation and HPV vaccination. So folks here who follow religion A are not likely to vaccinate their daughters, and everybody else is likely to vaccinate their daughters. So this is an example of attribute disclosure. So here we can learn that people of religion A are not likely, the probabilities are pretty strong, they're not likely to vaccinate their daughters. Now, from a public health perspective, that's not good because you're exposing these girls to potentially devastating disease later in life, and they may pass it on as well. We learn something new about people who are affiliated with religion A, and we learn something about them whether they're in the data or not. So this is attribute disclosure. Learning something new about and I don't know which record in this database belongs to Bob. So learning something new about individuals in a data set or have a certain characteristic is attribute disclosure, and it's not covered in, you don't have to worry about this. So oftentimes privacy concerns about data sharing center around what people do with the data, what type of analytics people run on the data set. And sometimes these analytics may be offensive or stigmatizing. That's not an issue with identifiability. So in this slide, I've suppressed the data. So some folks have suggested that to protect against this kind of disclosure, you have to suppress or remove records so as to hide this relationship because you want to protect against attribute disclosure. So now we've removed some of these records and we end up with this table, and the relationship has completely disappeared. But what we've done here is we've essentially destroyed the data set. So protecting against attribute disclosure is essentially protecting against doing meaningful statistics. So technical solutions are going to be very damaging to the quality of the data, and attribute disclosure is not covered by HIPAA, and it requires governance type solutions rather than technical solutions. So then coming to the issue of stigmatizing analytics, in practice this is what we see. So we have on one side re-identifying individuals or records in the database, and in the columns learning something new. So in quadrant 1, if we're not able to re-identify individuals, so there's no identity disclosure, and we don't learn something new, then there are no privacy issues, and you can share the data. Then essentially, it's not protected health information, and there's no risk of attribute disclosure. In quadrant number 2, we may learn something new, but we do not re-identify individuals. So that's the example I gave you with HPV. So this is not an identity disclosure issue, and therefore it's not covered under the regulations. Quadrant number 3, there's an identity disclosure, but we do not learn something new. Now, in practice, in terms of my interactions with regulators and just working in this field, this is generally not seen as a problem. So let me give you a simple example. Let's say there is a case of botulism, and you release the data showing one person, a 26-year-old male, had botulism this year. And there's a newspaper article that came out also that said Bob was the person who got botulism, and he's 26-year-old. So in order to know that the record that was released from the public health agency is Bob, you would have read the newspaper article, and the newspaper article told you that it was a 26-year-old male. So all the information that was needed to determine the identity of the record would have been known in advance to re-identify the record. So you don't actually learn something new through the data release because the information was already known. So that's an example of re-identifying a record that was released but not learning something new. In practice, that has not been considered a privacy issue, and regulators have permitted the disclosure of this kind of data, even though an individual can be identified. And then quadrant 4 is when there is no, when you learn something new, and of course there's identity disclosure, then that's considered personal health information, and that's a reidentification risk, and therefore you need to de-identify the data. So all this to say is that we are only concerned with quadrant 4, because that's the one where reidentification risk becomes important and where you start applying the standards in the HIPAA Privacy Rule. Okay, so now let's dig in a little bit deeper, talk about reidentification risk and de-identification. So no one would argue that direct identifiers can identify individuals and can uniquely identify individuals in the database. So things like the name, with some exceptions, of course, because names like John Smith are quite common. So it's either the name or combinations, individual or combinations of these direct identifiers. So you have the name, the address, the telephone number, fax number, medical record number, health card number, health plan beneficiary number, license plates number, email address, photograph, biometric, social security number, social insurance number, and implanted device number. These are all considered direct identifiers in the sense that they can uniquely identify an individual. And whenever you want to de-identify a data set, you of course have to deal with that information. If it exists in a data set, that information, those fields have to be dealt with. So HIPAA provides two standards for de-identification, the privacy rule, and they're known as safe harbor or and the statistical method. So the two standards for creating data sets that are considered de-identified and after which you can disclose without obtaining authorization of the patients. Safe harbor has 18 elements, as I'm showing you here on the screen. So the top one is name, and actually there a good number of these direct identifiers are included in here. So you have to remove all the direct identifiers. So under safe harbor, if you remove those 18 elements, then the data set is considered de-identified. For names, we are talking only about the names of the individuals or of their relatives, employers, or household members, but it doesn't cover the names of providers. And then you have element 18, which is a kind of catch-all, which is any other unique identifying number, characteristic, or code. And this is interpreted to mean a clinical record number, a characteristic such as a rare and visible diagnosis, and a code which could be, for example, a hashed social security number or a hashed medical record number. Something derived from a direct identifier would be considered a code. So all of these would have to be removed. Now, notice that elements 2 and 3 was not in our list of direct identifiers. You have zip codes and dates. And the inclusion of those two elements in safe harbor presents a number of challenges. So let me talk a little bit about safe harbor and how you can comply with safe harbor if you choose to use safe harbor as your standard for de-identification. Well, you can just remove the 18 elements. Anything that fits those 18 elements, definitions, you can just remove them from your database, and you're done, and you're in compliance. What I see sometimes in practice is organizations that do not remove those fields. And there are some good reasons why you may not want to remove the fields. For example, if you are creating a data set from a production database and you want to use it for testing or for demonstration or for training purposes of a particular software application, then you will need to maintain all the fields in the database. You cannot actually remove fields completely. So in that case, you may do some masking or modifications to those direct identifiers, the name and the telephone number, fax numbers, etc. So some of the techniques that are used don't actually work. So I'll just give you a couple of examples because I see these often, and it's good to understand what works and what doesn't work. So one kind of technique that's sometimes used with names is to scramble the names. So you have Smith, and you essentially shuffle the letters in the name, and you get TMHIS, for example, and that's considered a scrambling of the name, and we're done. So we did just a quick analysis using data published by the Census Bureau in terms of first and last names. And for first names, 60% of the names have unique characters. So shuffling names is still not going to protect the names for 60% of the most common names based on census data. So this kind of character shuffling is not really very protective. Another approach that's used is to crop or chop off the last character of a name as a way to protect it. And again, by looking at census data, we found that 67% of the names are still unique if you remove one character, and 46% are still unique if you remove two characters. So one has to be careful with what one does with those direct identifiers if you decide to keep them and claim that you are meeting the safe harbor standard. And if you try to do this truncation or cropping of fields, whether it's names or social security numbers or zip codes even, without having actual metrics on the uniqueness or how often the names appear or the values appear in the data set, you would not be able to know for sure whether the risk is managed or small enough or not. And the examples I gave you illustrate that. You had high percentages of names that were still unique after the scrambling or the truncation. The method that works well, which is easily defensible, is to randomize. So if you have a name, you just replace names with random values from a database, because then the probability of being able to reverse engineer the values, the replacement values, is quite small. And finally, I just want to mention you want to exercise caution with pseudonyms. If you replace, say, social security numbers or any other identifier or a name with a pseudonym, you'd want to make sure that it's not a reversible pseudonym. So a simple hash value, especially if you're talking about names or SSNs, could be reversed by just a brute force attack or by looking at frequencies of the names. So names occur with certain frequencies, and you just look at those frequencies, and you can guess the narrower set of names that a hashed value can take. So one needs to be cautious about the techniques used for safe harbor. But even if you do that, safe harbor has a number of important disadvantages as well as a de-identification standard. And therefore, generally, I do not recommend it except in some very specific instances. One is that it does not provide adequate protection in the sense that it's easy to have a safe harbor compliant data set that still has a high risk of re-identification. And you also may be removing too much information on the zip code and date fields. Now, recall earlier on that I mentioned that two fields in safe harbor were not direct identifiers, or usually not considered direct identifiers, zip code and the dates. You don't want to remove too much detail on those two fields, because for data analysis purposes, for analytics purposes, these represent very important information. Location information, if you're going to do any kind of geospatial analysis, absolutely critical in a lot of public health contexts. Reducing that or eliminating precise location can be quite problematic. And also for a lot of analysis, temporal information, the dates are quite important. So by truncating the dates and the zip codes significantly, you lose analytical ability. So I'll just discuss these 2 points for a couple of slides. The first example is I can create a safe harbor data set which has a very high risk of re-identification. It's an example of a simple example of actually why safe harbor is not protective. So let's say I'm releasing a database a table which has 3 records in it, only has 3 records. And I know Bob, my neighbor, is 56-year-old and he's male. But I also know Bob is in this database. This can be a database of men living in the neighborhood, people living in the neighborhood, or people who have visited a hospital recently, whatever. If I know that Bob is in the database, then I know that Bob is 55, not 56. Then I know that the first record belongs to Bob. And this is a safe harbor compliant database, and it meets all the requirements for the 18 elements, but because I know Bob is in the database, then I automatically know that record number 1 is him, and then I learn that the lab tests and potentially other fields in the database that belong to Bob. So when will I know that someone is in the database? If it's a population data set, so if this is, for example, all people with a particular type of cancer, let's say all prostate cancer patients in a county or in a state, or it could be a database where membership is known. For example, it could be a study that's being done in employees in a company, and people know who participated because employees who participated had to take a day off. Or it could be a study on or a survey of teenagers, and parents had to consent, so the parents would know that their kids were in the survey because they had to consent to it. And then if that data set is publicly released or shared afterwards, they would know that their kid is in that data set. So that's a simple example illustrating that when you meet that condition, when it's possible to know that an individual is in the database, Safe Harbor provides no protection. And then the second example, this is a real data set. This is the New York Discharge Abstract data for 2007. There are 2.24 million visits and there are 1.6 million patients. And I created a Safe Harbor compliant data set with age, gender, and ZIP3. And for that population of patients, so these are patients who have been hospitalized, on age, gender, and ZIP3, 2.54% of the patients are unique. By some standards, that would be considered a high uniqueness value. And if you add age, gender, ZIP3, which is again Safe Harbor compliant, and then length of stay, then 21.5% of the records are unique, which is definitely a high reidentification risk value. So when you're talking about longitudinal data sets, even if they're compliant with Safe Harbor, they may not. They may still have a high reidentification risk. Now, the other thing that is important to note is that Safe Harbor is maybe overprotective in some cases. So here's an analysis based on census data again, and so this is for all of the U.S. And here we're looking at gender, ZIP3, and year for the whole population. So this is this information, this demographic information, with ZIP3 and date of birth reduced to year is compliant with Safe Harbor, and 0.0001% of the population is unique on those 3 values. So that's quite small, very small, if you meet the requirements in Safe Harbor. Now, if we say we want ZIP5. So we have, again, for the whole country, we have ZIP5, year of birth, and gender, and now 0.17% of the population is unique. Now 0.17% would be considered by most standards, and I will talk about standards later on, as a very low risk. So having ZIP5 data and year of birth under certain conditions would be considered a low risk and an acceptable risk for releasing data. By reducing it to ZIP3, we've ensured tiny risk, but with ZIP5, the risk is still quite small. And also, it varies by state. So here we're looking at the data set for California, and we have ZIP5, age in years, and gender, and 0.05% of the population is unique on those 3 pieces of information. So that is quite a small percentage. And if you now, in some cases, looking at whether individuals are unique or not is considered too lenient. So if we consider people who are in groups of 5 or less as high risk of reidentification, then you see in the chart in front of you for California the percentage of the population on zip 5 gender and year of birth who are in groups of 5 or less is 0.4%. So again, quite a small percentage. And as I mentioned, it varies by state. So for the state of New York, the same information is almost twice the percentage for California. So the point is that it varies by state. So region does matter. And the assumption of what's acceptable risk is important. So are you going to look at unique individuals in the population, or are you going to look at people in groups of 5 or less? And then what is the standard? Is 0.5% acceptable? Is 1%, 5%? 10% acceptable. Cancer data is released with 5% uniqueness for researchers and 20% unique for researchers and 5% for higher risk releases such as public releases. So it's 5% uniqueness an acceptable standard. So one has to define what is acceptable risk and what group size one is thinking about, and then we can start to quantify and understand whether a data release is acceptable or not. Safe Harbor doesn't cover any of that. It just defines very strict elements. And therefore, this prescriptiveness, I think, well, as I illustrated, makes us lose opportunities for releasing more data, but still protecting privacy, but also maybe removing too much data in some instances. So it may not be protective enough in some instances as well. So it kind of works both ways at both ends of the spectrum, depending on what kind of data set you're looking at and whether it's cross-sectional, longitudinal, etc. So the next standard in HIPAA is the statistical method. And the wording from the privacy rule is on your screen. And essentially, it's kind of like a certification process. An expert certifies that the risk is very small. So a key word in the regulations or key phrase is very small. What is very small risk? And that's not defined. That's the point I brought earlier on about is 0.5% acceptable or not? Is the uniqueness or groups of 5 or groups of 10 acceptable or not? That is what is very small. So what we have been doing is we developed this methodology that will allow you to quantify in a defensible way what is very small risk. And we've been applying this for the last 3 or 4 years now to identify and release data sets. And so we look at identifiability as falling on a spectrum. And the numbers you see here are essentially probabilities of reidentification, vary from 0.33 to 0.05. These numbers, or that probability is, that set of probabilities is the set of values that have been used thus far for releasing all types of personal information: health data, justice data, education data, census data. We reviewed the policies and procedures of large data custodians, guidebooks, national statistical agencies, court judgments, regulator orders, and the range of levels that have been stipulated falls within those two. Within the 0.33 to 0.05 range. So you would use a higher threshold, which is a 0.33 probability of reidentification, when you're releasing data to highly secure and trusted data recipients. So if you're giving data to someone who is known to have very good practices in place that you can audit and verify, or if the data is not very sensitive, there's very little motive to re-identify, and so on. This would be a low-risk transaction. So in that case, you can justify very small risk being 0.33. At the other end of the spectrum is a 0.05 probability, which is used when you have a high-risk transaction, and that would be in a public release kind of data on the web type scenario where there's no security and you have no idea what individuals will do. And then for the values in between, we look at 3 factors which are shown here: mitigating controls, invasion of privacy, and motives and capacity. to decide which one of those 4 bins you should use. If you're not at the highly trusted or you're not at the public data release, then which one of the 2 thresholds or levels that you should use in the middle. And those 3 factors are, again, we went back and looked at what people who have been releasing data for the last 2 or 3 decades have been doing, and they look at these factors in an experiential way. So we've tried to formalize this, but essentially mitigating controls looks at the security and privacy practices of the data recipient. Invasion of privacy looks at the sensitivity of the data, and then motives and capacity looks at the motives of the data recipient to re-identify the data and their capacity to do so. So this gives us a very structured way to define what very small is. So to close, I'll just walk you through a very quick, simple example to illustrate kind of how we put all the pieces together. So the example is the California Hospital Discharge Database, and let's say we're going to we have a hospital discharge database or a discharge database, and we're going to release it to a data analytics company who will sign a data use agreement, and we've using the factors that I mentioned, mitigating controls and so on, we assess them and we determine that they have good practices for managing sensitive health information. This particular data set had 2.1 million patients, and they had about 3 million visits over that across them. In terms of the threshold, based on our risk assessment, we are setting a threshold of 0.2, so that's a probability of reidentification, one of the 4 bins that I showed you earlier on. And we're going to use average risk. There are different types of risk that one can use. Risk metrics. You can look at the maximum risk of reidentification. You can look at the average risk of reidentification. You can look at reidentification of a single person. You can look at the proportion of records that can be successfully matched if someone tries to match your data set with, say, a voter registration list. So I'm just going to look at average risk. And the fields we're looking at were year of birth, gender, year of admission, days since last visit, and length of stay. And zip code is not there because California doesn't release zip code information for its hospital discharge data sets. So on those 5 fields, it's a longitudinal data set. These are visits over a year. Our preliminary risk assessment showed that the average risk is 0.22, so it's just above our threshold, and 2.67% of the records or the patients in that data set had a risk that was higher than our threshold. So we can accept that 2.6% are high risk, or we can de-identify the data to eliminate the risk and bring it down to the average of 0.2, and no records or no patients have a risk above our threshold. Again, just from our own experiences doing this, we use hierarchies to de-identify data sets. So we generalize fields, and the reason we generalize fields is because it has very high acceptability among the data analysts. So here are some examples of hierarchies. The length of stay hierarchy is you have length of stay in days up to the first week, and then weeks after that up until 7 weeks, and then you have a top coding. So everything above 7 weeks is one category. So that's an example of a grouping, and then if you go up the hierarchy, there's even more grouping, etc. Same thing for days since last service, for birth year, 5-year groups, or 10-year groups. So these kinds of hierarchies produce data sets that have high acceptability. We tried adding noise and various other shuffling, swapping, and data users don't like that kind of data. They don't want to use them. Plus, adding noise has issues in that there are ways to reverse engineer noise by applying various analytic techniques. You can, in some cases, remove noise from data sets and recover the original data. So hierarchies and de-identification by reducing precision is a very effective way for de-identifying data sets. And of course, also you can suppress records, remove records, or remove values from the database. So after we applied the de-identification, on this particular data set, as you can see here, the risk was 0. 0% of the data set was at risk. 0.12. The average risk was 0.12, which is below our threshold. And what we ended up doing here was converting days since last service into intervals of months. So that allows you to examine readmissions within a month, which is a very common type of question when you're looking at this kind of data. And then length of stay was generalized into individual days up to the first 7 days, and then weeks up to 7 weeks, and then a top code or a group of 7 weeks and above. That's just an example. It's not necessarily the best way to identify this data, but it's one way that you can eliminate the risk so that the average risk is below the threshold that was determined. So with that, I will close. I just wanted to give you the link to the website. So I don't know if Yasmina, you can push the URL as well. That's where we've put the slide deck and the links to all the articles that I mentioned throughout the presentation. So you'll find them all there, so you can pursue these points later on. And then I think now we'll start taking questions.
Great presentation, Khaled. Very, very informative and fascinating. We do indeed have several questions that have come in. And folks, we did push out to you, probably opened another window. It is the URL Khaled just mentioned to his website where you can get a copy of the presentation and lots of good resources there. Khaled, the questions are in the Q&A box. Are you able to see them?
Yes. So I'll read the question and then respond to it. So the first question was, would storing patient information along with prescriptions be a HIPAA concern? Well, as I mentioned, the most defensible way to do this is to measure the actual reidentification risk on the data set. So it'll depend on a number of things, whether it's possible to know who's in the data set and what other fields are included in the data set. The more information in the data set, the higher the risk. But in general, it also depends what you mean by other patient information. If you have the full date of birth, that increases the risk quite a bit. Is it just year of birth? That will reduce the risk quite a bit. The other thing to note is that it is possible to predict other information about a patient from their prescriptions. And this is something we've done a number of studies on where we asked healthcare professionals to predict information that was missing. And drug information is very powerful because with that you can predict relatively accurately. Healthcare professionals, so pharmacists, for example, can predict accurately the diagnosis. And once you know the diagnosis, then it's relatively easy to take the next step to labs. So suddenly from the prescriptions you can get relatively accurate diagnosis and lab data, and now you have a wealth of information about the patients, and so the risk of that reconstructed data set can be much higher than just the prescription data alone at the outset. So there are a number of considerations you have to keep in mind, but it'll depend on the case and the specifics of the data set. The next comment was, the problem is that the disclosure of a number of attributes may reveal someone's identity. Absolutely right. The more attributes that you disclose, the greater the probability of determining someone's identity. But again, I would say that can be measured. If you're able to measure the risk based on a set of attributes, then you can decide whether it's too much risk or not. And if it's too much, then you can transform the data to reduce it to an acceptable level. So again, it'll depend on what field you're looking at and the characteristics of the data set. And the next comment actually reinforces that, is that it would seem logical that the more attributes would increase the risk of an identity disclosure. It is more variables, but it is more data points as well. Yes, I mean, in general, the addition of variables increases your risk. Adding more data points, as in records or observations, in general, that will reduce your risk, but there are some exceptions as well. In some cases, having depending on the type of attack you consider, in some cases having a rare, for example, a rare diagnosis may be more protective rather than increase your risk. So there's some subtleties there, but in general, the more data points, the lower your re-identification risks. The next question was, what role do you see for data perturbation simulation methods as a complement, adjunct, or alternative to rigorous de-identification metrics? Data perturbation can mean many different things. It could mean adding noise, for example, swapping and shuffling. So again, it comes back to measuring the risk. I think this is really important, and the reason it's important is we see a lot of techniques being tried out in practice, and with no evidence or metrics to demonstrate that the risk is acceptably low, it's hard to know whether what was done is protective of against identity disclosure or not. So if the perturbation techniques can demonstrate that the risk is acceptably low, then that's great, and you should use them. If you don't have the metrics to demonstrate that, then I think that would be a risky exercise. The other thing that I mentioned about the addition of noise, this is whether it's Gaussian or Laplace, for example, is that it is potentially reversible, and there has been a literature in other disciplines about removal of noise, but there's recently been also literature on removal of noise in the privacy arena, and a number of techniques have been developed to essentially average out the noise and recover the original data. So one has to be very careful with noise addition as a data perturbation technique. Again, I'm talking about if you ever have to go and defend this in front of a regulator or go to court. You want to have something that there's evidence that can support it, at least at the time that it was used. The other one was use of simulation. Absolutely, if you can create synthetic data, then that would be great. If you can create synthetic data that has the same characteristics as the original data, and that will be accepted by the data users. Our experience has been when you're talking to epidemiologists or biostatisticians or individuals who are trying to analyze health data to discover possibly causal or even predictive relationships for that would be applicable to treatments. There's extreme caution, and synthetic data or simulated data is not always received very well because of concerns that conclusions drawn may not be accurate, and then those conclusions would have an impact on actual treatment. So one has to keep that in mind when creating data sets for release for analytics purposes. If you're going to use the data to test software, for example, then it may not matter if it's simulated data. But if you're going to release data for some data analysis purposes, then it may matter a lot whether the analysts are comfortable with conclusions they draw using that data. So the next question is, what are your thoughts about open medical data from Sage Bionetworks, the Personal Genome Project, or CAGI? So that's very that requires a very lengthy answer, but the short answer is the protection of genomic data is very challenging. The attack scenarios are the plausibility of attack scenarios is still quite low, but it will not necessarily remain low for a long time, and especially if you start combining genomic with data with phenotypes for those individuals, then becomes multiple paths for reidentification. So, but there are good ways to protect that data, which essentially combine methods from de-identification, from secure computation and governance mechanisms. So I think it's doable. Now, the other issue is whether people volunteer their own data and put it online. That's a topic that requires, I think, its own session to discuss the implications of that on the individuals and their families, and the ethics and consent mechanisms around that. Okay, a question about whether optometrists are considered healthcare professionals. Good question. I don't know. I can't answer that question. I think you need to talk to a HIPAA lawyer on that one. I haven't encountered that before, so yeah, I can't respond. The next question was, can subsampling be used to avoid the problem of known group membership in a data set? Absolutely. Subsampling is a powerful way to manage risk or reduce the risk. But again, it depends on which risk metrics you're using. If your risk metric is average risk, then subsampling would reduce it. If you're looking at a maximum risk, then it will have subsampling will have little impact. So should you be using maximum or average risk? I think both of them are defensible. Average risk will result in lower risk values than maximum risk. That maximum risk is more conservative, and it's suitable under certain conditions. For example, for public data releases, but for data releases to trusted business partners or researchers, an average risk is defensible. In that case, subsampling can be a very powerful way to reduce risk, yes. But again, you have to measure it. So you have to determine what the appropriate sampling fraction should be in order to ensure that your risk is below your thresholds, in order to have confidence that you've done enough. The next question is there any decrease in risk by running databases in parallel, one identified and the other de-identified? The only released data from the latter, which is the de-identified database, or does running an additional database not worth the cost involved? Well, I think if you have authority to maintain an identified database, then you can just maintain the identified data, identifiable data. I'm assuming you would run a de-identified database because you have to disclose it, and there's a requirement, either because you're a covered entity or because of contractual obligations or terms of use obligations to de-identify the data. So my sense is it's one or you can, I guess you can have both situations. You can have the identifiable permission to use identifiable data under certain conditions, and then you have to de-identify it for other types of uses. So actually, it will also depend on how the data is used and what the legal conditions are for different types of purposes. So for one purpose, you may be able to use identifiable data, but for another purpose, you may not be able to, and you have to de-identify it. So I think the answer is maybe yes. It really depends on the context and whether you're allowed to for those purposes, you're allowed to have identifiable or not identifiable data through HIPAA or contracts or terms of use.
Right. I'm not seeing any additional questions coming in the queue. So with that, Dr. Khalid, on behalf of O'Reilly Media, we say a very big thank you to you, sir, for sharing all your knowledge and expertise with us. Folks that attended the event, we thank you for attending today and hope you benefited from it. And we'd also like to say a big thank you to those of you that sent in your questions, because having those questions just adds so much more to our event. And Dr. Khalid, as I'm looking in the group chat, people are saying thank you to you. Very, very fascinating webcast. They do enjoy it and appreciate it. So thank you, Dr. Khalid. Thank you, everyone. This will conclude today's webcast. Goodbye, everybody.
Thank you. Goodbye.